Our next session has a little change since Dr. Sumit Ray could not make it. He's down with fever. Hope he gets well soon. So we have our next session. The topic is weaning from ventilation, and would like to invite the chairpersons for the same, Dr. Anil Kumar. Dr. Anil is a senior consultant and head critical care medicine at Santosh Medical College. He's also founder and president Healthcare Skills Foundation, also executive member of ISCCM Ghaziabad, author of book Short Textbook of Anesthesia, Practical Manual of Practical Examination in Critical Care and Emergency Medicine, Comprehensive Manual of Resuscitation. He's actively involved in education, training and research. We welcome you, sir. Dr. Anil, please step on stage. I would also request Dr. Vishal Bhatnagar, our senior consultant critical care, to kindly chair the session along with sir. Dr. Vishal.
Welcome, delegates.
Just my sincere thanks to my brother Kamal, because it was just a last minute request. Just 1 hour back we requested him and he agreed. Thank you Kamal.
So I have not prepared well, but it will be interactive, coming from my experience as well as from the delegates. So my topic is it's easy winning the patient from mechanical ventilation. Intubating the patient is also difficult, especially in onco patient, because of the risk of infection. You always think twice before intubating the oncology patients. And it is furthermore more difficult to wean off the patient from the onco patient, because they are so much asthenic and weakness and so much metabolic abnormalities. So it is even more difficult to extubate them. So what is the definition of weaning? Weaning is defined as the entire process of liberating the patient from the mechanical support and the endotracheal tube. So weaning failure is defined as the failure to pass SBT or the need for reintubation or NIV support within 48 hours. For some author, it may be said that it is within 72 hours following the extubation. It is a famous weaning process published by Bowles in 2007. So you first treat the acute respiratory failure and suspect readiness to wean immediately. Of course, the cause of the weaning should always be at least partially reversed, even if it is not fully reversed, but it should be partially reversed. So what is the definition? From the first separation attempt, if the patient passes the extubation, it's a simple weaning. But if within 7 days it takes 2 or 3 spontaneous breathing trials, it becomes a difficult weaning. So after 7 days and more than 3 SBT, it is a prolonged weaning. The problem with the paper by Bose was it excluded lama patients and death patients and transformed for other. So epidemiologically as well as for the further research, they again the paper was published by the Wind study. So they included transfers or death before any separation attempt. Also the epidemiology was greatly discussed, and they found out the successful weaning, first weaning, the mortality was only 5.8%. So in the group 2, from the difficult weaning 1 to till 7 days, mortality increased up to 16.5%. And group 3 hours after 7 days, mortality increased up to 30%. And some in some studies, the mortality in difficult weaning is up to 70%. Data varies depending upon the region. So what is the weaning path? First, you suspect always if the patient is ready to wean, because this is the most important factor. If you are not thinking and you are keeping the patient, yes, there is a asynchrony and you give atra and you give midas, you have to take the, after thinking the patient require SBT, you have to stop all the sedation, all the paralytic agents, and after passing the successful SBT, you have to check the patency of the airways for the secretion of clearance, and of course with no upper airway obstruction. So this is the process of weaning. First step, the weaning process starts at the time when the illness that led to the mechanical ventilation has at least partially resolved. Second step, please, it will never be fully resolved. You, if you think the cause or the you think it will be fully resolved, you will miss many of the patients from the spontaneous breathing trial. So it will further on increase the mortality. Second step is readiness to wean should be suspected early in the course of mechanical ventilation and assessed by objective criteria. The third step, this is a de facto litmus test, the SBT. It varies from region to region. In India, we practice a TPs trial. Some places you practice at, I think, pressure support ventilation trial. There's a difference in opinion. In Europe, they do only TPs trials. In America, they do only pressure support, most of the places. For the pulmonologists, usually they prefer, I think, pressure support trials, and the intensivists usually prefer the TPs trials. I don't know. I'll discuss this further on. Fourth step is the extubation, is the liberation from the endotracheal tube. So this is the readiness to wean criteria. The illness has partially resolved. Suppose the patient was presented with sepsis, sepsis has resolved, you have taken out the abscess, then PF ratio should be more than 200 mmHg, PEEP should be less than 5 cm, there should be hemodynamically instability, there may be mild vasopressor infusion, that is okay. There is an adequate level of consciousness, patient should be awake or easily aroused, there should be adequate cough and secretion management, and RSBI should be less than 100 after 2 minutes of SBT. So this is the third phase, spontaneous breathing, avoid sedation, stop sedation, sit the patient upright, alleviate fears, this is very important, alleviate fears and ensure a calm atmosphere. Obtain baseline, because psychological dependence on the onco patients are very high, especially the prolonged ventilation. So alleviate fears and ensure a calm atmosphere. Obtain the baseline values and record them according to your set protocols. Fit the AT tube to T tube. This I prefer T tube in my ICU, depend upon the patient to patient. Attached to a heated nebulizer with an inspired oxygen concentration of 10% greater than that prevailing during the previous course of MV. And T tube flow, of course, exceeds the patient's peak inspiratory flow. The duration of SBT in the majority of the patient, a 30-minute trial is adequate enough, but Dr. Sumitre's topic was about individualized sepsis. So I think mechanical ventilation extubation should also be individualized. Protocol can be modulated according to the patient. So in the majority of 30-minute trial is adequate, but I still feel it should be individualized approach. Every patient is different. You can exceed the trial up to 120 minutes and maybe even more, especially in COPD and heart failure and neuromuscular disorders. So during the initial few minutes of SBT, the patient should be attentively monitored. You should check the change in rate, depth and pattern. So if they never appear, these three things never appear, discontinuation is most likely will happen. But if they appear, observe closely for deterioration, this thing will happen. So this is the failed spontaneous breathing trial. There is a very famous paper by Dr. Deepak Talwar and Vikas Dogra. Sternocleidomastoid activity will increase. There will be suprasternal recession, intercostal recession, tachycardia, diaphoresis, cyanosis, tachypnea, and abdominal paradox. So this is the criteria for successful SBT. Respiratory rate should be less than 35. Heart rate should be less than 130. Heart rate variability should not be more than 20%. PF ratio, as well as on the minimal vasopressor, and there should be no sign of distress. So this is the fourth step of extubation. There should be adequate cuff reflex. I always check for shoulders shrugging. I never, especially in the onco patient, there should be a good power enough. If there is no shoulder shrugging at all, even though GCS is full, I always defer the ventilation. Should be cuffs, not only cuff reflex, cuff strength should also be very good. The patient should be able to protect airway and following simple verbal commands. Secretion should not be copious. Cuff leak of less than 110 ml measured during the I don't think it is required cuff leak test. It is no longer recommended. No radiological or surgical procedure planned in near future. Extubation should not be done at the end of the day, never. This is very important. Never extubate the patient at 5 p.m., 6 p.m. or 7 p.m. Try to do early in the morning. So this is the criteria of the failure of the SBT. I already discussed in this picture. So protocol directed weaning, I think it should be individualized. But some of the protocols are mandatory. I think they give you fair idea who will pass the successful, like a PF ratio, minimal vasopressors. But it should be individualized, and you can increase the duration of the SBT also. This is one of the weaning protocol we follow in our ICU. So once the patient had meets all the readiness criteria, we begin with the TPS trial and observe for the signs of the failure of extubation. These are the weaning parameters. I never use these parameters. I simply put the patient on TPS, observe the patient. The most important thing is individualize the extubation and identify the patient. Identification of the patient is more important before putting on the patient of the SBT. Out of this RSBI I use, but I don't rely on RSBI also too much. It is only upon the patient. So procedure to obtain this is one of the procedures. I think everybody know about this frequency divided by tidal volume, breaths per minute per liter. RSBI more than 105 combined with respiratory rate more than 38 breaths per minute, one of the best predictors of field weaning, but no evidence of any change in clinical outcome. Sometimes RSBI may be higher side, but we have been able to successfully extubate those patients. It is very important to extubate onco patients, give them a fair chance, because the risk of mortality becomes very, very high after 7 days. So which weaning method? So I'll come to the controversy. So which method, sir, do you use in your ICU? There is still a, I think there is still a physiological controversy kind of going in Europe. Most of the intensivists, maybe anesthetists, they always prefer TPS trial rather than pressure support. But I feel TPS is a more tougher test. If the patient fails the TPS test, most of the patients will miss the chance of successful extubation. Yes, yes. But physiologically, I think pressure support would be better because it recruits the expiratory muscles. It recruits because you are breathing at a new equilibrium volume. So expiratory meter take over the inspiratory effort also. In some of the patient, I think it should be again individualized. Yes. Also, I think PEEP also mitigates this glottic normal physiological PEEP. Okay.
Whatever parameter or protocol you utilize, if you're not spending time with the patient, not able to.
But European guidelines suggest TP style, and American they say only patient support is better. So ACCP ATS 2017 guidelines support the PS augmentation of 5 to 7 centimeter water of beef. Just according to me, it is more physiologically beneficial because expiratory muscles take the load out of the inspiratory muscles at the top of the equilibrium volumes, and also the some amount of PEEP is required. Suppose I have extubated the patient, there is some kind of physiological PEEP loss when you put the patient on TPs actually. See, you are just there is some kind of physiological loss, so you have to give some amount of PEEP, I think. So again, to check the cuff strength also, sometimes TPs is more beneficial. It is very difficult to check the cuff strength on pressure support sometimes, although it shows the flow, but the card says test and etc. It can be more easily done on the TPs. So whatever you want to do, anything but not SIMV. It is out. Some people use these days, but anything but not an SIMV. It is the least efficient most of the times. Anything but CPAP most of the times. This is what I feel. Anything but small amount of PEEP is necessary, but never SIMV. Most frequent reasons for weaning failure according to the three groups: simple weaning, delayed awakening. We don't stop the yatracurium, midazolam infusion, and there is a lack of the screening. It is the most important factor which increases the mortality. And the difficult weaning, who require up to 3, it's or again the left ventricular failure and the fluid overload. According to me, for the simple weaning, we just don't start the protocol. The second, most of the time it is fluid overload, and for the oncocritical care, it is always weakness and especially diaphragmatic muscle weakness. So 3 most common causes of the failing as first SBT: incomplete resolution of critical illness, errors in assessing the readiness to wean, and the presence of a new problem, new cardiac problem. Most of the times I have seen about 40% of the case it is a cardiac problem. So again, how do you manage the apparent and hidden difficulties from the mechanical ventilation? So there is inadequate reversal of the narcotics. Fentanyl is going on, it has accumulated more enough, decreasing the respiratory rate. I don't know, I have not seen oncocritical patients, but I have seen the chronic patients. I don't know, Wernicke's encephalopathy and these metabolic abnormalities I think should be more common in onco patients. So all the nutritional deficiencies, especially vitamin B1, and you have to do cortisol levels, and thyroid hormone should be checked, especially in onco critical care patients. And of course ventilator dysynchrony and increasing loads. The tube is blocking, you have to check. Frequent bronchoscopy I think is required, especially in onco patient when you are suspecting the tube blockage. So unnecessary elastic load and unnecessary resistive load and the inadequate reversal of the paralysis. So the major barriers, there is always in everything in the body works with the like a market, a supply and demand, what I feel, everything in the body. So so Weaning supplies a very famous paper. I like this paper by McIntyre, published in 2005. Mechanical ventilation needed, intolerable load. You are putting more resistive load. Patient is incomplete reversal of the paralytic agents, decreased phosphate, decreased potassium levels, and there is so less reserve the capabilities like neural drive and muscle function strength. So when the supply and demand gets disbalanced, you cannot take out the patient. So you have to check it. You have to check metabolic requirements, either respiratory drive is increased, frequently check the potassium level, provide adequate nutrition, remove all the resistive loads like the tube wall blockage, give bronchodilators to the patient if requires. So again, the increased elastic load, increased resistive load, secretions, ETT problems, increased ventilatory demand, decreased ventilatory drive, decreased calcium, magnesium phosphate, requirement of steroids, fresh onset sepsis, hypothyroidism, unilateral phrenic nerve injury, decreased neuromuscular capacity, oversedation, metabolic alkalosis, OHS, cardiac disease, factors affecting respiratory mechanics, again same thing. Again the very famous diagram. When you have patient, put the patient on TPs, there is a decrease in intrathoracic pressure, increase LV afterload, and immediately patient fails. Most of the important cause is decrease in the cardiac output of the patient. Patient goes into failure. Immediately you put the patient either on pressure support or on TPs. The increase in the CO2 also increases the pulmonary vascular resistance, which in turn increases the RV dilatation and increases the work of breathing also. So how you diagnose it? I already told you. I have made a mnemonic, I think, for easy. I just fast forward the slide. I think no space over there. So I think I have deleted that one. It's the old slide. So increased inspiratory muscle workload, whether the ventilator flow pattern is synchronized with the patient's demand, consider the usage of extrinsic PEEP, treat underlying disease and optimize airway function, use bronchodilators and of course tracheostomy, and for impaired neuromuscular capacity, optimize sedation, muscle training, early mobilization to the maximum workload. As much as he can tolerate, mobilize the patient. Minimize patient ventricular asynchrony, rest if respiratory muscle exists, provide adequate energy intake. So this is in my ICU, I think this is the most important cause of the weaning failure, especially in the first 7 days, cardiac dysfunction. And it has been found in various studies, it can go up to more than 40 volume overload because of kidney, cardiorenal syndrome. It's a vicious cycle. So you perform and leading to myocardial, you should perform 12-lead ECG, do echocardiography, perform VTI index, BNP measurement, and pulmonary artery catheter, optimize fluid balance, diuretics, restrictive fluid management. Always try to de-resuscitate the patient afterwards once you have recovered from the patient from the sepsis. Treat appropriately if myocardial ischemia exists, use beta blockers, antiplatelet therapy, use nitrates in uncontrolled hypertension. So these are the metabolic and endocrine abnormal measurements of electrolyte. I told you earlier, all hormones, thyroid, cortisol, etc. NIV and HFNC, it can help in the management of the weaning failure only as a facilitation technique. Never try to use NIV, just you have to extubate the patient because most likely you will fail. So it is recommended only in COPD patients who have PaCO2 of more than 45 mmHg. It is recommended in patients with high risk factors for respiratory. No evidence of benefit except in surgical patients, especially multiple trauma, chest trauma. So role of tracheostomy, of course, it decreases the dead space. The most difficult thing for weaning of the patient from the difficult weaning or prolonged weaning, how to identify which patients who require tracheostomy. It is very, very difficult. How to identify? Of course, it improves patient discomfort. There is a lesser requirement of sedation. There is a lower work of weaning, faster weaning from mechanical, lower risk of VAP, lower mortality, shorter intensive care unit and hospital stay. But the quality of evidence is very low, especially for the lower risk of VAP. This is very controversial. The quality of evidence is very, but yes, several RCTs have showed it requires lesser sedation, and one RCT has showed it is a faster weaning from the mechanical ventilation. But risk of the VAP data is very controversial. So timing of tracheostomy, consider performing tracheostomy when the patients are predicted to require prolonged mechanical ventilation more than 14 days. So early tracheostomy less than 10 days was associated with shorter duration of sedation, lower long-term mortality rates than late tracheostomy, lower VAP rates, shorter duration of mechanical ventilation ICU stay, but not with reduced short-term all-cause mortality. So this is the effects of prolonged passive ventilation. There is oxidative stress. Most important factor which causes diaphragmatic weakness according to me is geometrical distortion in COPD patients, which happens, use of the steroids, use of the diuretic causing metabolic alkalosis, plus direct effect of atracurium and the paralytic agent on diaphragm, which causes atrophy as early as 5 to 7 days, which is of course diffuse, I think, more commonly found on right side rather than left side. These are diaphragmatic myofibrillis from an infant ventilated for 47 days. So rapid disuse atrophy of diaphragm fibers in mechanically ventilated human beings, you can see. So we regularly do this thing, we check the diaphragmatic excursion and diaphragmatic thickening. So I think take home message, less is more, avoid unnecessary sedation, and I think we should stop using atracurium for any asynchrony at all. Better to put the patient from volume control mode when he goes into pressure support mode. It helps rather to give atracurium. So daily screening for the spontaneous breathing trial, protocolized weaning strategy, quickly intervene when an SBT fails. There is no evidence that a gradual reduction of ventilation support accelerates the ventilator discontinuation process. There may be substantial benefits to early extubation and institution of NIPPV tracheostomy in prolonged weaning failure. Thank you.
Weaning. I think weaning is more of a clinical challenge rather than going
through these steps, protocols, and ultimately it is a continuous reassessment of the weaning process. And the first is basically depends on the indication for which the patient has been intubated. That basically decides tracheostomy will not be a challenge to go ahead with tracheostomy if I have a large tracheal bleed. But challenge comes when you are in a borderline situation where you feel this patient might require 15 days or 20 days, basically PRDS. So there also is the trick is until you are coming down on the ventilatory needs, you will not be able to do a tracheostomy immediately. So it is more of a clinical challenge. Again, individualized. Again, rather than protocolized. And if you look at sort of newer to the diaphragmatic part, asynchrony becomes sort of crucial development in terms of not able to wean. And our weaning eyesight little less towards actually atracurium and asynchrony. So when we are looking at the resident level, the most easiest part is to sedate them, keep them atracurium, knock them down, and again sit there we stop the sedation. That directly injures the diaphragm muscle. I do agree, but there are still some indications of atracurium in critical care, where we are actually looking at fight beneficial for some duration of time. Very short duration. Very short duration. I think weaning is hard.
Can I share something? So first of all, thank you, Dr. Kamal, for giving such a simple presentation, and I really liked your approach, the way you have simplified the presentation. There are 2-3 things I felt I should add on as far as your contribution is considered. The one, as far as the weaning mode is considered, I think it's more of driven based on the center to center. If you see the French ICUs, they are still using SIMV mode for the weaning. So saying this thing absolutely blatantly that the only modes which can be used for the weaning modes, that is going to be a CPAP or your TPs, is overdue. And in fact, the French ICUs, they have one of the best, the extubation rates. So that is one I wanted to share. The second, I wanted to... Yeah, that's what I'm saying. So you have to actually see it from that perspective as well. Now, as far as your point is considered, Dr. Anil, when you said that weaning is a clinical based service. I agree to it. That may be a partial modification which I want to say. Every patient in ICU deserve a spontaneous awakening trial and a spontaneous breathing trial. You have to objectify the weaning. Because half of the times when we fail is an under-assessment. And then you never give the patient a trial for, the weaning. So that is why you have to give, that is where the protocol bundles. No, let's. No, Dr. Kamal, we can always discuss this thing. I just wanted to add some points. So the second point is this. The third thing which I wanted to say that as far as the CPAP versus the TP's controversy is considered, there is a recent paper, it's a meta-analysis which is published in New England Journal of Medicine. I think I encourage each one of us to witness that paper, where they have said there is no difference between the outcome, but nevertheless, the patients who are at risk for weaning failure, if you put them on TPs, it serves as an acid test. So the patients who are predisposed at risk for extubation failure, if you're putting them on TPs, it's something which is going to act as a gold standard in those subset of population. But having said so, the patients who require some kind of, the PEEP effects because of the heart failure and all, they should continue to be on a CPAP-based weaning strategy. Thank you.
Thank you, Doctor. Anil, the basic thing regarding the critical care is, and regarding the ventilator is, use that particular mode for which you are more comfortable. There is no fast hard and fast food. And the first prerequisite for the weaning is that resolution of the cause for which you kept the patient on a ventilator. And as the Dr. Anil has said, look at all those parameters, make a protocol, a weaning protocol. Moment that you put a patient on the ventilator, follow that form, make your team members to fill that form, so at least objectively you are following those criteria. But still, even after following that, you have a good number of the patients who cannot be taken off the ventilator nicely. Thank you very much.
Trials as well as the trials. Both are important, depending on your size, but at least it should be able to work with what we have to do. And thanks for the nice presentation. And at the last
Thank you so much, everyone. I would now request our Director Medical Oncology, Dr. Vineet Talwar, to kindly felicitate the speaker of the session, Dr. Kamal. Dr. Kamal, kindly step on the stage, please. Thank you.